Thank you so much for having me. And our topic today is COVID-19, SARS-CoV-2, and novel coronavirus. And this is a new topic for me because it's a new topic for the world. This is a very complicated, difficult topic, and I want you to bear with me. I have lots of information to help you with, and I'm hoping that we can cover this and that you will feel at the end empowered, feel more protected, and able to cope with everything that's going on in the world. I want to tell you that what we're going to cover today is the biology of this virus, how it infects us, the symptoms, how it's transmitted, how we test for it, how it can be prevented. No, first slide still. Its treatment and the vaccinations. But to start, I want to talk about what is this and why do we call it this? There are three names at the top of the slide. COVID-19 is coronavirus disease 19 because it's coronavirus disease from 2019. Still on the first slide.
I'm sorry, I'm so sorry.
So COVID-19 is the name of the disease. SARS-CoV-2 is severe acute respiratory syndrome, or coronavirus 2, because we already had a SARS-CoV, because we had a coronavirus that caused SARS several years ago, and this is the second one that causes disease. So COVID-19 is the disease. SARS-CoV-2 is the virus. You're going to see these things in the media, and you should know that there is a difference. But when it first came out, it was a new coronavirus, and so they called it novel, meaning new, or novel coronavirus. But I've been looking at this for quite a while because of my patients, because of the medical world, and in trying to present this. So I'm on a first name basis with it, and I just call it coronavirus. So if I refer to coronavirus, this is what I'm talking about. There are other coronaviruses, but for us, coronavirus is SARS-CoV-2. Now I want you to look at this slide for a minute. I'm sure you've seen lots of pictures about this because I know you've all been reading, but we're going to talk about this for a while, and I want you to have this picture in your head. This is an electron micrograph. It is an actual photograph of the virus, and it really highlights the little red spikes. These are protein spikes on a round ball, and you can see that this is a round virus. And this is important for how it is designed, how it infects us, and how we can target things that will help treat it, and how we can target vaccines. So keep this in your mind, and then we're going to move forward. I've lost there. We'll move forward in terms of what we do next. So we're going to start with a little biology. What is a virus? A virus is just a piece of genetic information. It's either an RNA virus or a DNA virus. It's just got a little bit of genes in it. It's not even alive. And a virus's job is to make more of itself. And it uses a host to reproduce. It's like a pirate, and it jumps in and it grabs something. It could grab a bacteria, it could grab a human, it could grab a dog or a bat, and then it gets into a cell and it starts to make more of itself. And along the way, it often mutates or changes. So on this slide, you can see that this is a virus getting into a cell, and it uses different parts of the cell to reproduce. It uses the Golgi apparatus, and the viral DNA attaches to the ribosomes, takes the host cell's DNA in the nucleus, and attacks it, tells it, no, make more of me, and then the host cell's DNA makes more of the virus, and then more viral cells are sent out, or more viral RNA cells or DNA are sent out. Now, our coronavirus is an RNA virus. Other RNA viruses would be HIV or Ebola. DNA viruses might be influenza. So this is an RNA virus. Coronaviruses tend to be pretty big. HIV would be a small virus. Coronaviruses tend to be bigger viruses. Okay, next slide. Viruses cause infections. How do we get a virus? This particular virus invades us through the nose, the mouth, or the eyes. It comes in and it tends not to stay there, but get down deeper into the lower respiratory tract, like the trachea, or down deep into the bronchial tree and actually into the alveoli, which are the little air sacs. And there are receptors there called ACE, which are angiotensin converting enzyme receptors. ACE2 specifically are the main receptors for that. And what happens is that this, remember the little ball with the spikes? It's like a lock and key. It's very particular that it can attach to these ACE receptors, and it gets in and then it invades these cells, and that's where it starts reproducing more. And the lungs and our intestines seem to have a lot of ACE receptors. Now, what's interesting is children don't have many ACE receptors. They can receive the virus, they can reproduce the virus, they can spit the virus out and infect us, but they tend not to get as ill because they're not absorbing the virus deep into them. Now, the other thing is that people who have high blood pressure, heart disease, atherosclerosis, they have more ACE receptors. And so they tend to get sicker. That's at least one of the hypotheses. We don't know this all for sure, but this is one of the hypotheses that has emerged in the medical literature. So this virus has come in through the nose, the mouth, the eyes, travels down into the lower respiratory tract where it's starting to copy itself. It's getting into our cells, taking over our cells, using our DNA to then make more of itself. And then it stimulates the immune system. But it doesn't do the right kind of stimulating the immune system. What's supposed to happen is you're supposed to say, hello, interferon, show up, get rid of this. That's what would happen if, say, we ate some bad food and we had like staph poisoning. It would say, oh, please, and you might have a little diarrhea, you'd be better in 24 hours because our immune system would take care of it. But it hides a bit from our system and it doesn't really respond to our initial fighting. So instead it is reproducing, hiding from interferon, and then all of a sudden it makes the immune system go bonkers and the immune system starts working super overtime. And that's where you start to see things that are, we call it the cytokine crisis, where you've got too much of the immune system and it's hyperstimulated, and that's when you see bottoming out of the blood pressure and all of those crazy things going on, and that's where people get extremely ill. And the other thing that it's, one of the other things it's doing is it's irritating the lining of the small arteries. We have little arteries that go through the whole body, and the lining of those arteries is called the endothelium. These arteries get irritated and they start to swell up and they start to bleed. We have small arteries everywhere in the body, and this virus, when it is overwhelming the body, will irritate linings of the arteries in the lungs, in the heart, in the small little arteries down in the toes. You've heard of COVID toes, in the brain. It can be in the entire body. The other thing that this virus does is it makes our platelets go nuts. Now, in the blood, we have red blood cells, we have white blood cells, and we have platelets. Platelets are our first line of defense if we bleed. You have a little cut, the platelets will arrive, and the platelets will start to make the clot. Well, this coronavirus makes our platelets start to rise so that instead of having maybe 100,000 platelets, now we have 400,000 platelets or 600,000 platelets, and it makes them very, very sticky. And those clots start to go where they don't belong. We could have clots in the lungs, like a pulmonary embolism, clots in the intestine, giving us ischemia in the intestine, clots in the heart, giving us heart attacks, clots in the brain, giving us stroke. So this infection causes not just problems in the lungs, where it goes to the lungs and starts scarring and we get pneumonia and we can't breathe and we end up on the ventilator, problems in the intestines, giving us problems with difficulty with indigestion, diarrhea, vomiting, lung damage and scarring, hyperstimulating the immune system with cytokine crisis, or irritating the small arteries all over the body with with inflammation of the endothelium, and then this clotting problem. So this is when you have massive infection from coronavirus. Next slide. Loretta? So what are the symptoms? Now you should have already figured out the major symptoms, right? Fever over 100.4, cough or sore throat, difficulty breathing. The CDC says these are the three main ones. These are the major symptoms. Chills come from stimulating the immune system. You start to get rigors and chills. Muscle pain, new loss of taste or smell. That's a sign that the neurological system is involved. Nausea or vomiting and diarrhea. Those are the GI symptoms, or headache. So these are the big symptoms, but if you think about what I just said, we can see other things. We see the COVID toes when they have the inflammation of the arterioles that are in the little toes. We could have chest pain is a very typical sign. We get headache, we have stroke, we have heart attack. But the beginning symptoms are the fever, the cough, and the difficulty breathing. These are the things that we seem to see first. But this is a symptom where we see this whole spectrum. We have people who are infected with COVID who have zero symptoms. They don't know it. They are spewing viral particles and they don't even know they have it. And then we have some people who they present where they're just instantly critically ill and they don't even realize it. It becomes very, very difficult to even function and they end up on the ventilator because they go from nothing to sick. Most of the time, though, it's somewhere in this spectrum, and you can see fever over 100, cough, or difficulty breathing. Those are considered the hallmark symptoms. But chills, muscle pain, loss of smell, loss of taste, nausea, vomiting, diarrhea, headache. These are very common symptoms of COVID-19. Okay, next slide. Now we're going to talk about transmission. How do you get it? This is a droplet transmitted disease. So you see this slide and you have this little group of family with the people in gray and then a couple people in red. They're going to be transmitting it. And what happens is somebody is spewing out particles and they are sending it from themselves to other people. The two main ways is they are either transmitting it directly out or the particles go out and then they go onto surfaces where the droplets linger and somebody touches them and then puts them in their own onto their face or getting it into their system. So we're going to talk for a minute about spewing out the particles. There's the direct transmission and then the aerosolized particles. So direct transmission would be you are not wearing a mask and you are in the presence of somebody with the disease. They breathe, you breathe it in, now you have the disease. That's what happened in Wuhan in Italy. You have the people walking around, they have the disease and they talk to each other, somebody coughs, somebody breathes in, and now the disease is transmitted. And then it goes from one person to the next person to the next person. And it only takes 1,000 viral particles to transmit. When you breathe out anywhere from 50 to 5,000 viral particles. When you cough, it's about 3,000. And if you sneeze, it could be up to 30,000 viral particles. So if somebody doesn't feel well and they sneeze and you're nearby, you can just get that right in you and that's it. One sneeze and you're contaminated. Then we have the droplets that are in the air. So if a lot of people are breathing and they're in the air and it's still air that's not really circulating, like for example, in a church, in a bar, in an elevator, then those droplets can remain in the air and then you can inhale them. So if 10 people are in the elevator and 3 are infected and they're breathing and you're breathing it in, then you can become infected. And then we have the droplets that come out and fall down, and they fall down onto, say, a mouse, and then you come and you touch that computer mouse, you could get it. That was a problem in the hospitals. The doctors were cross-contaminating because everybody has to use the electronic record and they didn't realize that the mouse was contaminated, or the telephone, okay? Or you're in the bathroom and you wash your hands, but then you touch the surface again. You touch the tap to turn it off, but the person behind you, the first person had used it, they had the coronavirus, so they put the tap on, you go and then you touch the tap again. So surfaces can contain, and they can live on different surfaces for a long period of time. It lives on copper just a few hours, but it can live on a surface of hard plastic or granite for up to 72 hours. So droplets are important. It's probably not as important as somebody's coughing or breathing on you, but it does matter. So droplet transmission is how this is transmitted. And being close matters because it looks like the transmission is approximately 2 meters or 6 feet is usually how far it is, so that the droplets will come out and then fall down because it's kind of a heavy droplet. There are other diseases like varicella, which chickenpox. Chickenpox is very light and it is super, super contagious. So if somebody has chickenpox and they were to walk in and they were around the corner, if they were like in my office in the waiting room and I was in my office in the back, I would be infected because it's so light and airy that just would come all the way in. But with a COVID-19 or coronavirus, if they were in my front office and I was in the back, it's too far for coronavirus to travel. It's a heavier droplet. It's going to fall to the floor. It's about 6 feet and then it's going to drop. Okay, next slide. Okay, so how do we test for this? You've heard about antigens and antibodies, but what's the difference and what are we testing? So over here, you see this green ball, which is a schematic of the coronavirus, which remember that we saw the first one with the red spikes. These are green, but the green ball with the green spikes, the green spikes represent the protein, but the green is the representation of the virus. The virus is what is the antigen. An antigen is anything that provokes our immune system. An antigen is anything that provokes the immune system. So in this case, it would be the coronavirus, but particularly this coronavirus, it's the proteins that on the spikes. That seems to be what's triggering our immune system. And in this schematic, you see these yellow Ys with the blue tips. These are antibodies. Antibodies are our defense. This is the cavalry. Da, 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 da. They're coming out and they're going to come and help us fight this and neutralize this virus. So antibodies will come, and if you look at this schematic, you see it's coming from all sides, and it's going to come in and it's grasping those little spikes and it's going to inactivate this coronavirus. So antigen is basically it's the virus because it's triggering our immune system. Antibody is the defense that the body creates. Now, we have more than one kind of antibody, and it is one part of our immune system. When we first see something that's not good, we will produce something called IgM, and that comes out usually within about a week to 14 days, and IgM goes up and then comes down, and then we start to produce IgG. That goes up and then comes down. So IgM comes first and then IgG, and it's two different kinds of antibody, and IgG lasts longer. Now, our immune system has other components. We have interferon, we have antibodies, and then we have T memory cells that will remember that we saw this virus, and it will come to the rescue again in the future. So antibodies are part of our immune system. It is not the whole immune system. Now, what are we testing for? We are testing mostly right now for antigens because we want to know who is contagious. And we are testing for antigens that are living in our nasal cavity or in our mouth. And so we're swabbing and we're testing. And there are different ways of doing this. And some of them are immediate, 45 minutes, and others take 2 to 3 days. And antigen testing will tell us, are you contagious? It takes about 4 or 5 days to develop enough virus in the body for us to know, are you infectious? So if you went out and then you came back and you said, I wonder if I got sick, you can't test that day. It's too soon. You need about 4 or 5 days. Antibody testing is your blood response. So that is a blood test. And you have to capture those antibodies really 2 to 6 weeks after you've recovered or after you've been exposed to the virus, after you've been sick. So let's supposing you had been exposed, now you've been sick, 2 to 4 weeks later, you can test for antibodies to see. Does that mean you're immune? We don't know yet. And the antibody tests are very variable. A lot of antibody tests came out which were not specific or sensitive enough for us to use medically. And antibodies come and go. And there are people who definitely had the disease and that definitely recovered, but their antibody tests were not high. Does that mean they're not immune? It might not. It might mean they are immune, but their antibody level did not stay elevated, but their T memory cells are going to work. So therefore, we are not really using antibody tests in the clinical world. They are using it in the research world. NIH and CDC and Hopkins are doing antibody harvesting, and the Red Cross is harvesting antibodies, and they're trying to use this to help patients who are currently very, very ill. And those studies are ongoing. Does that help people get better faster? And we're working on that now. But the general public, we're not doing antibody tests because it's not clear what that means or whether it means immunity or, and we don't have enough specific and sensitive antibody tests. But antigen testing we are doing right now. Okay, next slide. Okay, now, what I really want to help you with right now is how not to get the disease. There are many, many things we can do to keep ourselves safe, but there are 3 that are really, really critical, and I want to talk about them, and we're going to come back to some of them. So we're going to go through the slide, and then we're going to focus on a couple of things a lot more specifically. The first one is wash your hands, and we're going to come back to that. The second one is don't touch your eyes, nose, or mouth. And the reason is that we touch other things, and the virus gets in through our eyes, our nose, our mouth. Don't touch it. But it turns out people touch their eyes, nose, and mouth like 100 times a day. It's part of our instinct, you know, cut your hair, whatever. But be very careful. Learn new behavior. Don't touch. Don't hug, handshake, or direct contact other people. You don't know where they've been. And if you touch them, then you touch yourself. You can have whatever they've touched comes to you. And stay away from people who are sick. If they're sick, don't go there. If you don't feel well, stay home, especially if you have a fever, you're trouble breathing, or you're having any kind of chest pain or cough, stay home. And that's good advice no matter what. Now, cover your mouth with a tissue when you cough or sneeze. That actually has changed to wear a mask, wear a mask, wear a mask. And that's another topic that we're going to come back to in just a moment. If you use a tissue, throw it away. And throw it away deep. Don't let it be airborne. Just immediately throw it away. Disinfect your surfaces, such as desks and kitchen surfaces, and disinfect your keyboards and door handles. And we're gonna talk about that right now, just a little bit. There's a lot of discussion about what to use, and there's a big run on all sorts of sterilization, you know, Lysol and everything else. But if you just take 2 teaspoons of bleach in a cup of water, you can use that as a disinfectant solution. 2 teaspoons of bleach in 8 ounces of water and turn that into a spray. Or if you can get 70% alcohol, I mean, you know, isopropyl alcohol and not vodka, but using just alcohol, that disinfects your surfaces. Or soap and water. It doesn't have to be a formal Lysol product or Clorox product or something else. Just bleach or soap and water or alcohol will work. But you do need to clean, and you need to clean your doorknobs, you need to clean your high touch areas, you need to clean your sinks, you need to clean your faucets, you need to clean your keyboards, you need to clean your telephones, and you need to do this twice a day. And you just have to be good about it because we do touch stuff, and that it could develop droplets. If you go out and you come home from the supermarket, clean everything down. Anytime you've been out, you need to be cleaning. Clean, clean, clean. Now, masks. Masks really do matter. So if you think about the transmission, if you know that you need 1,000 viral particles to get in, anything that cuts down on that transmission matters. So We talk about the N95 masks. This would be an N95 mask. And it fits tight and it fits snug, but they're hard to get. And this particular N95 mask has a valve, which means the air is coming out and I am actually not protecting the next person because this valve is allowing my breath to come through. So you need an N95 mask without a valve. Anybody who's wearing a valve is not protecting you. So if you see people who are out who have valves in their mask, they are not protecting you. Stay extra far away. But the N95, this is, it's got the extra layers and it controls 95% of particles from getting in. So this is the most protective. You couldn't see the mask? Is that better?
How do you get to it?
Is that better? This is the surgical mask. Can you see me now? You can only see the slides. Okay. I didn't realize you could only see the slides.
I can see you. I can see the masks.
People
Okay, so some can see me.
go to speaker view. Speaker view will show her.
Better?
Good.
I'm seeing you just fine in gallery view and speaker view.
Okay. So this is the N95. This is a surgical mask. It's 3 layers. It's got the wire. If you use this, shape it to conform to your nose, wrap around, pull down snug and tight. If you do that, it's not going to foam up your glasses. You're going to be able to see just fine. But make sure it's snug and tight. If this is an N95, this is about 70%. It's about, if you wear it well and snug, it's about 70 to 80% protective. And it will help you. It will make the difference. And if you're wearing a mask and the other person is wearing a mask and they're 70% and you're 70%, together you have given a significant percentage of protection. This is a homemade mask. Now, the woman who made this for me was an ICU, an OR nurse in the operating room, but now she quilts. And she very smartly made it out of a very tight cotton weave. It's double layered, but she's got a 3rd layer in between, which is a filter. So this is a very high quality homemade mask. She used a wire in here, and then this is a ponytail scrunchie. And this fits very well. So this goes again over the nose, over the ears, pull down. And you can see that this could fit. So this is probably about 60%. If you use a single layer cotton, it helps some, but really not the same. So if you're going to use a homemade mask, try to get it to be 3 layers thick. Make sure it has a wire. I've seen a lot of people come in with no wire. So what happens is it's constantly dropping. And if it's dropping, you're not protected and the next person's not protected. So you want a well-fitted mask, 3 layers with a nasal wire so that it fits tight and it should be snug. If you have a small face, get a small mask. Make sure that it fits you. Now, let's talk for a minute about face shields. The face shield adds another layer of protection. And if you see, what it does is it protects around the eyes and it protects from the droplets from above. But it does not protect aerosolized particles. You must wear a face shield with a mask. It doesn't work instead of a mask, it's in addition to. So if you're going out to an environment that you think is high risk, you're going to a grocery store, you're going out somewhere where you're really worried that people are not behaving, you could wear a face shield and a mask. But you can't wear a face shield without a mask. It's not adequate protection. And masks protect you and they protect others. It works both ways. this idea that the masks only protect other people is just not true. It also protects the wearer. So just think about it. You're out and you're at the supermarket and somebody comes by who's not wearing a mask and they sneeze and they've got 200,000 particles at 200 miles per hour, but you've got a mask on, you have a significant degree of protection. If you have no protection on and somebody comes by and sneezes, you could be in trouble. Wear the mask. It matters. It matters quite a bit. Now I want to take a minute to talk about washing your hands. And I'm going to just go through this in detail because it turns out that people don't know how to wash their hands. And I'm a little stunned by this because washing your hands should be something that we all know how to do. So, you know, we've heard you're supposed to like sing happy birthday twice, but 20 seconds and you have to wash all your hands. But I actually don't sing happy birthday. I sing staying alive. All your hands, all your fingers. Be clean. Make sure you do your fingernails. It should be short. All your wrists.
Hi, Peggy. Jerry Sicker.
And the Bee Gees. And then wash. The water comes down and drains off. The water comes down and drains off. And then paper towel. And then you dry your hands and you use the paper towel to turn the tap off. Don't go touching, okay? If you touch the tap that's dirty, you've recontaminated. Wash your hands, wash your hands, wash your hands. And if you wash your hands 10 times in a day, your chances of getting sick are reduced dramatically, dramatically. Okay, so if you wash your hands, if you keep your distance, if you wear the mask, your chances of getting this are significantly reduced. So, you know, we talk about the 6 feet distance. The 6 feet is so the droplets fall off. We want you to, you know, use these precautions. You can't always keep the distance. That's why the mask matters. So if somebody comes to see me, we're going to be in my exam room. It's going to be a little closer. But if you're masked and you're keeping your distance, that matters. If you get closer in, it takes a few minutes to get infected. Don't stay a long time. If you go in an elevator, no more than 2 people and get on and get off. The other thing is air is your friend. So let's supposing that you want to see a few people. If you get together and you're outside and the air is circulating, then that should be safe. But eating together is higher risk than just being together because the saliva and you're unmasked and the transmission. Eating together indoors is a high risk activity. Going to church and going to bars is the same level of risk. It's super high risk. And in church, the singing is a big problem because you're spewing more viral particles. So church should be remote right now, or see if you can have an outdoor service and you can all be separated by a significant distance and everybody masked. Right now, air is your friend. If you can get out during this period of time, I think that's great. If you can be on a deck and it's big, get a fan. The circulation interrupts the transmission of the virus. So circulating air is your friend, getting together and you're 6 feet apart with the distance and you've got outdoor activities, that is much, much safer. Indoors is not. Now, there were 2 hairstylists in Missouri. They were wearing their masks and they went to work and they didn't feel well. They wore their masks, they washed their stations down, they washed their hands, and during the week they saw 139 people they came in contact with between receptionists and everything else. And at the end of the week they said, you know, we really feel like crap, and they went and got tested. They were both positive. 139 people they touched. Nobody got sick. Nobody. Because the clients were masked, the hairstylists were masked, they washed their stations and they washed their hands. These prevention measures work, but you have to do them and you have to be rigorous. You can't like put the mask on and pull it down to talk. You can't say, oh, well, we're going to do this, but we're just going to have a little meal together and then put the mask back on. You have to be rigorous. But if you're rigorous, it will work. Okay, next slide. Okay, if you do get sick, what's the treatment? If it's a mild case, it's just like treating the flu, if it's mild. Rest, fluids, good nutrition with antioxidants or chicken soup, self-isolate. You're at home, you're alone, you use your own bathroom, you don't eat with anybody, you stay by yourself, and take Tylenol if you need it. And just for a minute, let's talk about if it's a mild case. If you do everything I say and you still get a few viral particles, if the viral load is low, you're likely to get away with a little at-home treatment and a little mild illness. If you get a big inoculum, a lot of viral particles, you're likely to be sicker. But if it's just a few viral strands getting in and a small inoculum, a little viral load, you're more likely to get away with being at home and just a little bit of the disease. So if it's not perfect, it still may be okay. You may do better. So I'm hoping if you can't get away with nothing, that you just end up at home with rest, fluids, good nutrition, self-isolate, and Tylenol if needed. Now, one of the things we worry about is our oxygen levels. So one of the things that might be worth having on hand at home is an oxygen meter. So that's something that you just get like Amazon sells it. And we worry about people's oxygen level. So I don't know if you can see this, but this just measures oxygen level over time. Okay, so you can see my personal data. I'm at 98%. My pulse rate's 73. Okay, so my usual pulse rate is 62, so I'm a little hyped, can you tell? But all you do is put this on your finger. And so an oxygen level is usually 90 and above. Most people are about 95 or above. But we've had some patients who can end up with oxygen levels like in their 60s, and they just feel tired and they don't realize how sick they are. That's been a problem with the COVID-19. So having an oxygen meter at home, you should also have a thermometer at home. So having a thermometer to check your temperature and having an oxygen meter can give you guidelines as to how sick you are and whether you should stay at home or whether you do need to go to the hospital. And then, you know, we have these new thermometers where you just do your forehead and it just clicks and tells you how your temperature is. And that way you can tell us what the temperature is. If you have a fever of 100.4, you would call your doctor. If you have a fever of 102 and your oxygen level is low, time to go to the hospital. So those are sort of ways that you can tell how sick are you. Now, in the hospital, what are we doing for patients who are sick? And I just want to be proud of my medical colleagues, okay? The fatality rate in the hospital has dropped by over 75%. They have learned so much. We've all learned, okay? And the doctors in China, the doctors in Italy, the doctors in Seattle, the doctors in New York, everybody's communicating so that the doctors now in Texas, they are doing so many more things because everybody has learned from everybody along this path. And the rate of intubation has lowered. The people on the ventilators, there aren't as many, and the need for ventilators has declined, and the survival rate has increased dramatically. So if you should get sick, we can do more things for you. So what are we doing? We're doing respiratory support. We're giving oxygen. It turns out that sometimes people don't have to go on the ventilator. Some of you are on CPAP, which is like for when you have you need breathing and you need to force lungs in, but we're using BiPAP, which is a little more sophisticated than the CPAP with oxygen, but it puffs up the lungs without using the ventilator. Putting people prone or on their bellies changes the bellows function of the diaphragm, and they actually can breathe better. So putting people on their bellies in oxygen sometimes just improves their oxygenation enough. They don't have to go on the ventilator. Otherwise, putting people on the ventilator, on the breathing machine with a tube and breathing for them is the next step. The other thing is they're understanding better what are the ventilator settings that are appropriate for COVID-19 as opposed to some of the other respiratory failure settings because it's different. This is a different disease and they're understanding it better. So they're getting people on the ventilator and they're getting them off them earlier and better and with better survival. We talked about the platelets and the clots and the pulmonary embolism. They're testing them early. There's a blood test, a D-dimer test to tell whether they're making blood clots. They're testing their platelet levels, but they're starting them on heparin and they're starting them on antiplatelet medicine right away. And they're reducing the blood clotting early, and protecting people from heart attack, stroke, and pulmonary embolism from the get-go. The blood is more thick, it's a viscous. They have a hyperviscosity syndrome, so they're getting IV fluids on really aggressively. So the blood is less viscous, and that's improving the outcomes. Now, medications, they're trying all sorts of different kinds of medications, what works, what doesn't. And they're doing all sorts of different kinds of studies. Remdesivir started as an Ebola and hepatitis drug, and they're using that, and that seems to be targeting the virus directly. It helps. It's not the perfect drug, but it definitely improves. And what they're finding is they've tried it at different stages, and they need remdesivir for someone who is in the hospital, sick but not terribly sick. If you wait too late, it won't work. Hydroxychloroquine is up and down. Does it work? Does it not work? There may be a role for it. It may help with the cytokine crisis. There's lots of different studies. There was that terrible study in Lancet that was disproved. We're still looking at hydroxychloroquine, but its role is unclear. Dexamethasone is a prednisone. It's like a steroid, and that definitely helps inflammation, but they use it usually later on in people who are quite inflamed. We've been using dexamethasone for people with inflamed lungs for a long time. Interleukin 1 and 6, these are monoclonal antibodies, and we use those for rheumatoid arthritis, and we've used them for some other kinds of autoimmune disease, and we are using them for very severe cases, and they are helping people. So therefore, I'm finding that patients are responding, and it's sometimes not one or the other, it's everything. They come in, they're getting oxygen, they're getting persantine and heparin, they're getting IV fluids, and then the middle of the road, they're getting remdesivir, and then they're getting the dexamethasone, then maybe they're getting the interleukin 6. So what's going on is this combination, this multiple modalities are helping people to survive. Okay, next slide. Now I want to just mention the vaccines. Right now, if people are curious, you can go online and just put in coronavirus or COVID-19 vaccine tracker. There's 5 or 6 websites, including New York Times has one and something called RAPS, and they track the vaccines and where they are. But I wanted to mention just a couple of different things that are going on and how exciting it is. Medically, we're like making unbelievable progress. But I wanted to explain a little bit of the biology behind it so you could understand. So some people are taking adenovirus, which is another kind of a virus, and they're rechanging it up genetically and making it so that the adenovirus looks a little bit more like coronavirus, and then they are giving you that as an inactivated virus, and that will make you trigger antibodies to the new COVID-19. And Oxford University in England is doing that in combination with AstraZeneca and CanSino in China. They are both doing it. Those are 2 different vaccines, and they're doing a little bit of a different approach, but it's the same type of vaccine. It's an inactivated adenovirus that got genetically re-engineered to look like coronavirus. And they're in phase 3 trials right now. The next one is mRNA. Moderna's doing it, and then there's another one called BioNTech. Those are 2 different vaccines. They're both in phase 3 trials, but this is something that we have never seen before. We have never had a vaccine that's mRNA, and messenger RNA is a very interesting kind of RNA. It's sort of like a boss. It doesn't really do anything itself. It just tells things what to do. And messenger RNA comes in our cells and tells us things that have to happen. And the messenger RNA vaccine will come in and say, make antibiotics to coronavirus. And we do. It's very exciting. And it doesn't have any viral particles at all. And it's considered very safe, and it's working. And there are new phase 3 trials for that. There's 2 different ones. There's Moderna and there's another one. So there are 2 studies going on, both with mRNA. Sinovac in China is using an inactivated virus where they take the actual coronavirus and they inactivate it chemically, and then they use that. And we've all had inactivated virus particles for other vaccines, and that seems to be working. There's another virus, a vaccine. It's called BCG. It's a Bacille Calmette Guerin, which is a French name. And this is something we use for tuberculosis. We in the United States don't use it, but they do use it in Latin America and India. And this is interesting because people who received this vaccine do not seem to be getting bad coronavirus. So they are taking the BCG vaccine and they are, again, genetically engineering it to be a little more specific to coronavirus, and they are using that as a test. And the University of Melbourne is doing this in Australia, but they have coordinated with Mass General up in Boston, and they're trying this repurposed BCG. Now, the other thing is, going back to my original slide, those spike proteins really do intrigue the virologists. So Sanofi Pasteur has this fingertip patch, and they take sugar crystals, they add the proteins from this spike. They take these little proteins that came off the spike of the corona, put them on the sugar crystals, put them in a patch, and you put it on your finger. And then the body responds to those protein spikes by making antibodies to the coronavirus. You just wear the patch for a few hours and you're done. This is also very, very new technology. So it's very exciting. All right, that's it. So I think now we're going to go to questions.
Term effects of the coronavirus on people who tested positive but weren't hospitalized. Do you have any information on that?
So what we're finding is that the coronavirus causes all of these symptoms that we talked about. And we are finding that some patients recover fully. Other patients have a protracted course. And other patients, we don't know, are they going to be permanently damaged or not, because it's too soon to tell. There are some people who did not end up in the hospital who ended up with several months of fatigue, fever, GI disturbance, and shortness of breath, who still are having shortness of breath and weakness and fatigue, and who have not fully recovered, and it's 3 to 4 months out. I don't know what their long-term prognosis is. I don't think anybody does. And now they have, they've started recruiting observational trials. In Boston, they're doing one for sure. And they'll start to do studies for that now. I don't know the answers yet. It's too soon.
Next question is on getting flu shots and the pneumonia vaccine. How does that interact with the fact that we're in the midst of this epidemic? Should people hold off? Should you go ahead and get them?
We want you to get all the vaccines because all of it boosts your immune system and is helpful. And the other thing is you don't want to get both at the same time. And we're actually really advocating to get the flu shots because we don't want to have a flu pandemic or epidemic at the same time as a coronavirus pandemic. I can tell you though, I think I saw CVS is advertising it already. Please wait until the latter part of September at the earliest, because as people get older, they don't maintain their flu immunity as long, and it could only be 6 months, and you don't want to have your flu immunity run out in April and then end up with a May flu epidemic. And that has happened a couple years in a row because CVS keeps marketing it earlier and earlier. You really want to wait until the flu is going to be here and not do it just because it's available. So end of September is ideal time, but get the flu shot. Now, something that's interesting is in the Southern Hemisphere, which is a flu season now, is there's less flu because people are taking the precautions. They're washing their hands, they're wearing their masks, they're staying away, and they're not going out if they're sick. So they are actually not experiencing the flu epidemic, which they thought. It's interesting.
Next question is, if you are pretty much self-quarantining, you're staying at home pretty much all the time, and especially if you live alone, do you need to do the hand washing and cleaning of phones and computers and et cetera if you're the only one using them?
You don't have to be as vigorous, but you're eating, right? So where's the food coming from? Some things, you will still have things coming into the house from outside. So we still recommend that you be vigilant. You don't have to be as vigilant as, say, I do, where I'm in the office and people are coming in regularly from the outside world, but still things are coming in from the outside world. So I would still say you should be clean and as vigilant as you can, but not as much so as, say, I have to be. So it's a level of degree.
There was a question about the masks that, you know, we've heard many times that masks are primarily designed to help other people around you. But you seem to be indicating that they could also help you, the person who's wearing it, as well as the people around you. Can you say a little more about that?
Yeah. So they, you know, they say, I wear the mask to help you, you wear the mask to help me. But the truth is that you do have a degree of protection from wearing the mask yourself, especially if you wear it correctly. If you wear the mask and you put it on and you seal the nose and put it on and you pull it down and it seals, if somebody comes at you with viral particles, this mask is going to be probably a 50 to 70% reduction in the number of viral particles that I'm going to ingest. So it's going to give me a degree of protection. It's not 100%, but it will give me a degree of protection. And again, the lower the viral load, the better my immune system, the better the chance it is that my immune system is going to be able to help me mitigate the disease.
Another mask question on homemade masks. Should you put them on with the pleats facing up or down?
Down. And you should have a wire. The wire should be at the top, pleat should face down. Yeah, because you're going to pull it down, it's going to seal.
There were a number of questions that had to do with traveling and the risks of traveling, the safest ways to travel, and specific questions around sort of what to do if you have family member or a close friend who's at some distance and there's an emergency, you really need to get to them.
Okay, so I want to just mention that the governor has come out and said, please do not have any non-essential travel outside of the state. So people who've been vacationing, they have a vacation home in Massachusetts or in South Carolina. The governor has said, do not go. But I have had several patients who need to travel for health reasons or family members in distress.
Can I just interrupt for a second,
Yes.
Dr. T, and ask everybody to mute? There's some noise coming on from somebody, so please make sure you're muted. Go ahead, Dr. T.
If you're traveling, there are ways to travel that are safe. I do think the airports are not nearly as congested as usual. If you go to the airports, I do think you should make sure that your plane is one of those airlines that is not filling the middle seat. MIT came out with a study that said, if you fill the middle seat, just the sheer number of bodies with all that breathing going on, if somebody is positive, it raises your chance of getting it by 1,700%. That was a study at MIT. So not filling the middle seat reduces the number of breath particles in the air. So I know that 2 or 3 airlines are still committed to not filling the middle seat, and I think that's what you should choose. I think you should try, don't check bags. Don't hang around the airport any longer than you have to. Mail your bags out there. Just do a carry-on, get in the airport, get out of the airport. Wear your mask and try to get an N95 if you can, and if not, get a good mask, a tight-fitting mask, and maybe consider a face shield as well. And then the other thing is bring you would want to get a wipe or alcohol, and even though they say they're cleaning, you want to wipe down the back of the seat, and you want to wipe down the arms and the rest. And if it's a short flight, try not to use the bathroom, but if you have to use the bathroom, make sure that you wipe down again when you come back and use your hand sanitizer, okay? And if you use the hand sanitizer, it's the same drill, okay? You're going to be washing and cleaning all of the set, okay? It's the same drill that we just talked about. Make sure you get the whole hand, okay? Because if you don't, you could have lingering particles. So wash your hands, wash your hands, wash your hands. So if you have to travel, you go in, and the others, don't eat at the airport. Bring a granola bar or something that you can open up and get the food out and just eat it dry. Buy a bottle of water, drink a little water. Try minimize the food. It's eating too. You're touching your face, you're putting particles in. So really try to minimize that sort of stuff. But I've had several patients who've had to go elsewhere for family reasons and whatever, and they've traveled safely. Now, let's supposing you're driving. Your main risk is going to be the rest stop and the bathrooms. If somebody has coronavirus, they're going to excrete it in the stool. It's going to be in the bathroom, and then it can stay around the rim. And when you flush, it becomes airborne, and then that's an aerosolized particle. Again, mask on, and again, turn the tap off with your hands. Now, sometimes they don't have paper towels, and they have those air dryers. Those are terrible. They aerosolize everything. And then you're not just talking COVID, you're talking E. coli and everything else. Don't use them. Bring your own paper towels, wash your hands, and as soon as you get in the car, use the Purell or whatever. And be careful, buy the brand name or buy something, because these have been contaminated with methanol. So make sure that you're getting a good product if you're buying them. Okay.
What about super spreaders, Dr. T?
Super spreaders are the big problem, okay? There's a whole group of people who are ill. They have the virus. They don't know they have the virus, and they're spewing it out. That's why you have to wear the mask. It does matter, okay? It matters a lot. So they are out there spreading the virus. They are allowing it to drop on surfaces. They are breathing it in the air. They may not, or may be wearing a mask. We don't know. And so they are creating an environment that is making it high risk for everyone. That's why we have to stay home. That's why we have to wash our hands. That's why we have to wear our masks. And unfortunately, a lot of the super spreaders are the 15 to 30-year-olds, and they don't have the same worry that we do. Some of them are getting sick, some of them are dying, but many of them are just coming along, spreading it, and going along their merry way. And that's a big, big problem in our community.
How often do you need to change or wash your mask?
So if it's soiled, you have to wash it. It really varies with how much you're using it. So if you go to the supermarket and you only use it for an hour, then you could use it maybe 4 or 5 times, and then you should wash it. But if you use it for 5 or 6 hours all day, then you probably should wash it, you know, every day. So it depends on what the use is. If it looks dirty, if it smells, it's got to be washed. So it really depends on what the utilization is. Any mask that smells or looks soiled has to be washed. If you only use it for an hour and you air it out, then you could reuse it several times. So it varies with the use.
What do you, what would you recommend to somebody who was considering being a volunteer in one of the vaccine testing protocols?
So I always appreciate anybody who volunteers. I am a little worried about people getting the placebo, because, but some of the protocols will give you the placebo, or, you know, you don't know whether if it's a double blind, that means that you might get the placebo, but some of these protocols will then say to you, well, at the end, if you got the placebo, we will give you the vaccine. So then that would be okay with me. They've already gone through phase 1 and phase 2, so they've already proven safety, and they've already proven preliminary efficacy, meaning that they seem to be working. And we have 2 in our neighborhood, because we have one at University of Maryland and one at NIH. And so therefore, those are pretty reasonable options for people. So if it were me, I would say, okay, I'm willing to try. I'm even willing to go through a placebo controlled, as long as you promise me that at the end of the study, I'll get the real vaccine if I got the placebo.
Are people still at high risk if they have health conditions that are under control? You know, maybe they have diabetes or high blood pressure or whatever, but it's under control. Are they still at high risk?
Okay, so we're figuring that out. Okay, so I have to say that that's an individual question. I do know that if you have high blood pressure, diabetes, heart disease that's not under control, that's the worst, no question. If it's under control, some of it depends on the underlying damage that occurred prior to you getting it under control. So if you had 3 or 4 heart attacks and you have a lot of hardening of the arteries and a lot of atherosclerotic disease, and now right now you're in a stable state, but you've had all that buildup of atherosclerosis, you're probably still pretty high risk, even though right now your chest pain's under control. And if you've had diabetes for 45 years, I'd still really worry, even if your A1C is perfect right now, you probably are a high risk patient. But if you've been super good with your A1C and your blood pressure's been controlled for years, you may not be as high risk. You probably are in better shape. So I think that that is a little bit of an individual answer kind of thing. And some of it is we don't really know the answer yet. Well-controlled illness is still better than not well-controlled. That I can tell you. And I do want to say something else. We talked about this ACE inhibitor, and people are taking ACE medicines, right? They take lisinopril, or they take ARBs, they take losartan. Stay on those medicines. They may protect you. They certainly don't seem to be hurting you. They've done some studies on that already. University of Pennsylvania had a pretty good study early on, like in April. Don't stop those medicines just because they have the same initials and because they target similar areas. They are not to be stopped. They do help control.
Dr. T, what's the difference between the mail order rapid tests and tests offered through the county health departments?
Okay, so we're talking antigen testing, and the antigen testing from the county health departments are accurate. They're done at LabCorp. A lot of them are LabCorp. Then we have these rapid antigen testing that, like, they're starting to turn around. I think MedStar's offering them, and they're talking about offering them more. Those are going to be not quite as accurate, but they're going to be faster turnaround time, and we're hoping to deploy them more because we could get more people tested, but they're not quite as accurate. So you sacrifice a little accuracy, but you get the faster turnaround time. So we're trying to figure that out. That's antigen testing. That's testing for infection for the actual virus. That's not antibody testing.
If I am going to buy my groceries during the senior hours at grocery stores, is that a good time to go, or am I increasing my risk because there are going to be more vulnerable populations at the store at those times?
No, you're probably better off doing it then, because hopefully it's the seniors who are being careful who are there, and most of them are early in the day prior to other people shopping. And they should limit the number of people allowed in the store. So I would say that's a better time to go.
Is there any way to eat outside at a restaurant safely?
Yes, you can do that if you are distant. You really want to keep your 6 feet distance and you want to be away. But I really do worry about eating out. I think curbside pickup and getting delivery, I think that's probably okay. But there's an issue here with the unmasked and sharing and the saliva and the server, and I'm worried about that still. I don't think our numbers are good enough to be doing that, and I think that worries me. But I think indoor eating is for sure a problem. So if you're going to eat, do it outside, do it in a cafe kind of environment, and let the air be your friend and let the air be circulating. You probably can get away with that if you're distant and all of that. But it wouldn't be my first choice.
Yeah, I think one of the things that you're saying, Dr. T, is to realize it's all a matter of there's some risk, and there aren't any guarantees, especially because this is new and the science is constantly changing and catching up.
Right. And the other thing is our numbers are constantly changing and catching up, and it varies with what's going on in the community at any given time. And like our community, we've been a hotspot all along. We've had a lot of trouble. Now, if you're out, in Wyoming and nobody has it, then go out to the cafe, no problem. But here in Prince George's County and Montgomery County, this is a very high risk area. And who are the servers? The servers are the ones who are having trouble. So to go out and eat out, you're putting yourself at risk.
When you talked earlier about if you get a small viral load, that you're you're more likely to be able to recover without any major complications. But given the way you described how the virus spreads inside us, why wouldn't a small viral load just grow into a large one?
Okay, so it could, but hopefully what happens is our immune system does do its job and is capable of doing its job. So anytime we get a viral load, our immune system starts to work and starts to fight it. But if we have a large viral load, our immune system's overwhelmed and the virus is reproducing so fast that we don't have a chance of getting it under control. But a small viral load, a few strands, the antibodies are built up right away and our interferon works and the body is able to neutralize it itself quickly before it becomes overwhelming. But if you think about the doctor in Wuhan, who was the ophthalmologist, who was really brilliant, who recognized this in the community and tried to tell the world. He was doing an eye exam, was so close to a woman who had pneumonia, and she coughed in his face, whack. He was in his 30s, and he was dead like in a month, okay, because his system was overwhelmed by this huge viral load. So if he had had a few strands in his 30s, healthy guy, he probably would have survived. But a big whack from a woman with pneumonia, body couldn't handle it. So viral load matters.
What would you say to somebody who wanted to have someone come in and start cleaning their house?
So what happens now is if everybody is aware of what needs to happen and the cleaning crew is practicing safe practices, they should be wearing booties, they should be wearing masks, they should be wearing gloves, and you should sit on the porch and just stay outside and open all your windows and put your fans on. And if the house is ventilated, let them come and let them go. But then when they go, clean your doorknobs, clean your faucets again, and clean your high touch areas. Just wipe them down one more time.
How is obesity a risk factor?
So obesity is a risk factor for two reasons, but people think of fat as just sitting there like, oh, well, I have a little fat, it's okay. But fat is actually dynamic and it causes inflammation in the body and it changes how we metabolize things and it alters our immune system. So it can cause immunocompromise. It certainly affects the bellows function of the lung so that we don't ventilate as well. And it also, it changes how we respond to things, and it also causes hardening of the arteries, inflammation in the arteries, and it changes the way our receptors are. And people who are obese have more of these ACE receptors. So the whole combination makes them much more likely to have secondary complications from this disease.
If seniors are considered a high-risk group just by virtue of being a senior, even if you're otherwise healthy, can you talk a little bit about why that's the case? Why just being older is a risk factor?
There's a couple of different reasons why. One is that it seems like we get more of these ACE receptors as we age, just because we do. Our immune system also is slower to respond, and that's always true. If we give everybody a flu shot, a 20-year-old will get a huge number of antibodies, but older people might not respond at all. One of the reasons why we want to vaccinate the young is to protect the old. So just because we're aging, we have a slower response to these things. And then the other is we do get hardening of the arteries, and we do get vasculitis more easily, and we do have lots more high blood pressure. All of these things tend to happen. You can be in perfect shape, but you're still getting older, and the body has a natural aging process. There's something called senescence. The arteries, the cells, everything is just older. We respond more slowly. And so if you look at the fatality rates, they are much higher in this age group. Now, that's not true of every influenza or every pandemic. If you look at 1918, it was the young who died, and that was because it was all cytokine crisis. The immune system went bonkers much worse, and they died from the cytokine crisis. Here, it's more because the immune system is not responding as fast as it should. But it's usually because the immune system can't respond to the degree that it needs to respond to. And that's just purely a matter of aging. And all of us, as we get older, we do have changes in our body. We like to think we are perfect, but we are older, and that matters.
So Dr. T, we could probably hold you here for another 2 or 3 hours with questions, but we're already at the 1.5-hour mark almost. So I'm gonna stop peppering you. I will turn this back over to Lisa, but I just want to say thank you so very much. I don't know if you followed the comments, but there have been several people who've already typed in their appreciation for you and what a great presenter you are. So thank you so much for giving this information, so much needed. Thank you. Lisa?
Okay.
So also, there was one question that I really want to ask. I think you probably can see that many of us have not been getting haircuts. And there was a question about haircuts, which is going in and getting your haircut, is that okay? And do we have to do it outside? Do we need to persuade our haircutter to come to our house or do it outside?
Okay, so they too have their guidelines. And if they follow their guidelines, it's safe to go. So they need to be masked. They need to be limiting the number of people in the salon at any given time. And so you should, if you are going to a place that's following the guidelines, you can go safely. And they also need to do what I'm doing, okay? They need to be checking your temperature when you arrive. They need to be contact tracing. That is, you need to fill out a form and you need to agree that if anything happens, you're going to tell them, oh, you know what, I was in there 2 days ago, but 2 days later I got a fever. You have to tell them so they can trace whoever came in. You have to be masked, they have to be masked, they have to be washing. And if you go to a place where like it's only 3 people and they're all in different areas and you don't overlap with anybody else and you're wearing a mask, they're wearing a mask, they've checked your temperature and they're doing everything that way, it is safe to go. But I don't know if you can tell, but my hair is way longer than usual. This is my corona, can you tell?
Corona. So I think we're going to wrap up. I don't know if somebody, I just noticed that somebody had a new question. I'm going to look for it if I can find it. Actually, I think they're just saying thank you all. So I want to thank Dr. Traffolio. Loretta, do you have anything else that you want to add?
No, I just also want to say thank you so much. Dr. Traffolio, you've been an amazing presenter. Apologies again for the glitches in the beginning. Somebody's asking when the recording will be available. As quickly as I can figure out how to do it. And I will put it right away on the helpinghandsup.org website. I'll also send a follow-up email to everybody. So if you have ideas for other programming like this that we can do, there's clearly an interest. And so we'd be glad to work to put it together.
And I also see, I'm sorry, Loretta and Dr. Traffolio.
Question about going to the dentist.
Yeah.
Okay. Oh, actually, let me just say, you know, the medical world wants you to do the things that are necessary. The dentists are going nuts, but are working very, very hard. And so when you go in, you should see that they're wearing their shields, they're wearing their masks, and they have gotten